3, 2, 1. Okay. And we are live. Exercises Medicine on campus at Drexel University. I believe this is episode number 8 or 7.
8 or 9.
We're up to 8.
So probably 8, yeah.
Okay. So it is our distinct pleasure to have Dr. Randel Swanson from the University of Pennsylvania. Dr. Swanson comes at the recommendation of Nick Eltman, who is a student representative for this endeavor. And so, Nick, would you like to kind of provide a little context about how you know Randel, and then we can give Randel an opportunity to introduce himself to the audience?
Sure. So I met Dr. Swanson actually at the VA hospital. So very serendipitously, I just started to email a bunch of PM&R docs, physical med and rehab docs that were DOs at the VA hospital. And I really wanted to shadow one because I want to go into DO school and hopefully specialize in PM&R. And Dr. Swanson was the only one who responded to my email. And it honestly has been probably the best email decision I've ever made. And I started shadowing him for the last 2 years. And now I'm working under him with a research project. So hopefully developing a couple of case reports and systematic reviews. So
terrific.
Yeah. You want to introduce yourself?
Sure. So I'm Randel Swanson. So as Nick said, I'm an osteopathic physician. I also have a PhD technically in cell and molecular biology, but I study neuroscience. An assistant professor at the University of Pennsylvania. So my primary medical specialty is physical medicine and rehabilitation, and I'm a subspecialty certified in brain injury medicine. I also have an appointment at the Philadelphia VA. I'm one of the traumatic brain injury and polytrauma physicians there. So I treat patients across the spectrum of brain injury, traumatic brain injury from concussions to severe disorders of consciousness, and then other types of brain injuries like strokes, but also anoxic brain injuries from near drowning, things like that, electrocutions, different types of infections and tumors and stuff. So we do the long-term neurological rehabilitation. I also am funded. I run a research lab, and I guess we can get into that a little bit. My research is really looking at the impact of modifiable risk factors, largely modifiable cardiovascular risk factors, on long-term brain health after injury.
Very interesting. Very interesting. There's a lot of similarities in terms of the kind of work that I do in exercise physiology. And that's really, we are predominantly interested in what exercise can do to modifiable risk factors for chronic disease. And we explore those outcomes in a range of clinical and preclinical populations, most notably those who live with Alzheimer's disease and related dementias. Because currently there are no really medically prescribed, very precise recommendations outside of the 150 minute per week recommendation for most apparently healthy adults. And so what's really feasible, some of the nuances in terms of exercising alone, what a person can and can't do on their own. So there's a lot of overlap in that. So I'm very interested in hearing about your research here today. I guess one of the questions that I had to kind of get us kicked off is, what made you interested in this specific discipline of medicine? And compared to, we hear a lot of times students and faculty members who mentor students really sort of like, how did you know that osteopathic medicine was your thing?
Well, I think that I've always been more holistic, and I think let me think if I can get this right here. So that the tenets of osteopathic medicine are, number one, that the body is a unit, right? And then the person is a unit of mind, body, and spirit. But at the body level, instead of looking at the heart and looking at the kidneys and looking at the brain, it's that everything is integrated and everything needs to be functioning. The second thing is that the body has the innate ability to heal itself and for homeostasis and self-regulation. And the third tenet is that structure and function are reciprocally interrelated. And then the fourth major tenet is that rational treatment is, dependent on an understanding, a thorough understanding of those first three tenets. So that really spoke to me because of some of the personal experiences I've had in my life and things that I've seen where, so often people have a problem. They go to the doctor takes 2 minutes with them and they say, take this pill. And they don't advise them on any lifestyle factors that, could really change the trajectory. And so for me, in what I do in neurological rehabilitation, so let's say someone has a trauma. You're in a car accident. You have severe brain trauma. You might come to the ICU, and you might be operated on. You might be in the neurosurgery service for a day or two. Then you might spend a couple days to a couple weeks in the neurointensive care unit. Then you would go to a inpatient brain injury unit, and you might be our patient for several months to the rest of your life. And then we deal with all the chronic problems. So medicine is very good right now at treating trauma and acute problems. Mm-hmm. If you have a broken bone or something like this, an acute problem, we're very good at. We're very bad at treating the long-term chronic stuff. And, so from a brain injury standpoint, if you have even a severe brain injury, if you survive 2 years, the brain injury is not going to kill you. You're going to have a full life trajectory, maybe, die a few years earlier. But the same thing is going to kill you is going to kill everyone else. Number one thing across the world is cardiovascular disease. Mm-hmm. So specifically, we can get more in detail later about my specific research, but I had a lot of things happen where I did some research on the preclinical level, looking at microvascular pathology in the brain. That's traumatic microvascular pathology. So what we see in a pig model or in rodents and stuff acutely after an injury, how clearly you can see there's a microvascular injury. But then the body has the innate ability to heal. And by about 1 month after injury, we can't really see a difference in like the controlled animals.
Interesting.
Versus other colleagues and stuff that had, preclinical animal models of, let's say like diabetes, hypercholesterolemia, there's a progressive increase in microvascular pathology. So I really started looking at that. My research now is really looking at teasing out traumatic versus non-traumatic microvascular pathology and how I think that is a common endophenotype that's driving this accelerated age-related cognitive decline. I know I'm getting a little.
No, it's great.
Sorry.
It's great. I have like several questions. if I may be able to ask one question is, I've had some people in my life. One was an undergraduate mentor, so sort of the role that maybe I provide to Nick, this gentleman provided to me, and he was 42 years old and had a stroke. Right. And it was shocking because pretty young, I would think, but had a lot of sort of known hypertension that wasn't necessarily treated, very stressful lifestyle. Yeah. And so the signs were there that something needed to change. But what was interesting is, from your experience treating patients and maybe even in the context of your own research studies, are there certain risk factors or predictors that determine where the stroke is going to occur in the brain? So for example, in his particular case, it happened within the hypothalamus, and so he was, wide awake, and then 2 minutes later, just out cold, things like that. Yeah. Versus somebody who has it affected in maybe the premotor or motor cortex, where now there's, some significant paralysis. So from your perspective, are there certain risk factors that tend to associate, and are there any determinants of where it's going to occur?
So there's the majority of strokes, the overwhelming majority, are ischemic, which means the brain is being starved for oxygen, right? That's like, more than 85% of strokes. The less common is the ones that there's actually bleeding into the brain, okay? So the general risk factors are high blood pressure, high cholesterol, diabetes. And it's one cardiovascular system. So yes, there are certain pathways, like if you have a certain heart problem where you could have a blood clot in the heart that then could get thrown, there are certain pathways. But that's the minority. If we're looking at ischemic strokes where you got a pipe. So what I tell patients is this. Think about you have a brand new house. You got a brand new house, you got all the pipes in the house. Over the course of 40, 50, 60 years, the pipes start to get clogged up. The smaller the diameter to begin with, the easier it is to get clogged up. And then if you put grease down the drain, it's a whole heck of a lot easier to clog it up, okay? And so, really, a lot of what we see is people don't have a big stroke like your friend, like you were saying, but what's much more significant is little ischemia that we see in the brain we call white matter hyperintensity. So think about this. let's say, you're at the YMCA or something, or you have in a group shower where, you got the pipes coming out of the wall to the shower head. Mm-hmm. So that's like a major artery. And then you got the actual shower head that has 100 little holes on it that are little waters coming out.
Got a lot of branching.
Right, a lot of branching. If all of a sudden, you cut off the complete water supply to one of those pipes and that whole head is not getting water, that's what you think of as a stroke, mm-hmm. right? That's when the person has like a major event. What's much more common though is, like we've all seen in our shower, you just have a little bit of calcium build up and now water's not coming out of one quite right. And then you get these changes in the brain over time. And as people age, you get these what we call white matter hyperintensities and different ischemia. And that's what's accelerating this decline. But no, it's not like, you have atherosclerosis or this hardening of the arteries. It's a global phenomenon. The young guys, I say, and I learned this, I remember as a first-year medical student, when we're first starting to learn to interview patients, one of the first things they teach you to do is try to convince people to stop smoking. And for the guys, they say, listen, 30 to 40 years before you have a heart attack or stroke, you know what you're going to have? Erectile dysfunction. And that gets their eyes talking. So when I'm seeing patients, especially guys, we talk about that you don't have to go to the doctor to know if you've got cardiovascular disease. You can look at those measures. It's the same size little blood vessels, right? And so it's a global phenomenon. If someone has heart disease and atherosclerosis, they have it in the brain. They have it in all the arteries of the body. It's not like an isolated thing. Again, sure. The body is the unit, and it's all circulating around. And this is why, there's been huge trials. If we go to like the heart, for example, there's always people like, okay, you've got blockage. Let's go in and put a stent in, or let's bypass this. Mm-hmm. All the trials show that really doesn't work because you don't change your lifestyle. Think about, go back to the house. You got a house, you got all this junk clogging up the pipes. If you cut out a 1-foot section of pipe and you put a new pipe in there, but then you just let the water run around, it's going to reach equilibrium and get plaques and stuff all back over it.
Sure.
Right? So you're not treating the root cause. You're not going back to the root cause. You're just treating a symptom. So I know I didn't answer your question directly. The question is, no, we really can't tell it like that. Okay? Mm-hmm. It can go all over the place. And then it's just that of all the strokes, we go back, majority of them, they have high blood pressure, high cholesterol, prediabetes or diabetes, and it's going on for decades. Gotcha. It's not something that like happens right now, unless you've got some heart issue, you've got something, or you were born with a blood vessel anomaly that now you had a ruptured aneurysm or something like this. Mm. That's the minority.
Gotcha. Nick?
Yeah, that's really fascinating. I remember to really get into a lot of that stuff, and then personally, a lot of the research I'm doing right now is on CTE, mm-hmm. chronic traumatic encephalopathy. But what you kind of advocated me to read was the Lancet Commission's article that really pushed home the body as a unit, because there's so many things that affect brain health, like air quality and socialization and blah, blah, blah. And then physical activity is a big one. And all this stuff was really what's prompted me to encourage you to join here, because it's really just like, hey, exercise is medicine. You know what I mean?
Yeah. And if you think like the brain is about 2% of your overall body weight. So the brain's weight is about 2% of your body weight. But it receives about 20% of cardiac output. So every time your heart beats, the percentage of blood that goes to your brain versus the rest of your organs, your brain is receiving about 20%. It's said that there's about 400 miles of capillaries in your brain, tiniest little blood vessels. And they think that basically every little neuron has its own capillary. I mean, it's extensively vascular, right? So all of these things, exercise, nutrition, sleep, all of this stuff has a very big impact on this long-term brain health, which is brain health is cardiovascular health, is overall health, right?
Sure.
And what people don't realize, I myself included, right? So when I was I was in the military, right? So I was in the Marine Corps. Back then, I was chubby as a kid and all that stuff. I got in good shape playing high school football. I went in the Marine Corps. They kicked my butt, and we were exercising every day, and I was super skinny. I got out of the Marine Corps. Well, I was super skinny, but I could eat whatever I wanted. I got out of the Marine Corps and stopped exercising like that and ballooned up. And then I took my physical to go into medical school, and they're like, you have high cholesterol. We need to put you on these meds. We need to do all this stuff, right? What people don't realize is I think exercise is vitally important. I think, you can't outrun a bad diet, though. And there's a lot of people, especially when they're young, that are athletes, that think that I can eat whatever I want, and they don't realize that they're clogging their arteries and they're doing damage. It's going to catch up to them when they're 40, 50, 60.
Yeah, you got to eat high quality foods.
Right. So so it's a holistic thing. I don't think it's one or the other. And I think, though, that if people can have like a cornerstone habit, like let's say they start with exercise and just get them moving, get them doing something. And as they start feeling better, they're going to want to eat better food because they're going to get the association that, well, if I eat this crappy food, I'm not going to be able to perform as well, right?
Sure.
But you have some cornerstone habit. So, anyways.
Yeah, I think in terms of there's a lot that I think can be taken away that really relates to what this podcast is all about, and the information is that, a lot of times I would imagine that most of our listeners may be either faculty, staff, or students of Drexel that would perhaps use some of these resources. It's very hard when, say, you're a younger person, healthy. That's not going to happen to me, 18 to 22.
Yeah, you're invincible at that age.
Yeah.
It doesn't affect you necessarily today. And so, but to your point, it is affecting you. It's just, it hasn't manifested to the point where you're seeing this acute event where now all of a sudden your life could be drastically, or perhaps now it becomes much more of a threat. Someone has a heart attack, or somebody has a stroke, or somebody gets a diagnosis for cancer, all of a sudden now it becomes real, right? And so really what we try to do with this podcast and some of the resources that we develop is really, let's break down some of the barriers, because I think, we've talked with a lot of people now, almost 10 people, and some of the things that keep coming through is like, is it information? Is it behavior? And I think information is helpful to a certain perspective, but really it's the pragmatic process of how to implement and use the information to get on the track. And I think when you start building up, James Clear has a book called Atomic Habits, a really popular book.
I've read it.
It's a great book. I would highly recommend it to anybody that listens. Nick knows I'm like a really big bookworm. And I have an affinity for self-help and, ways I can optimize my life. And so in that book, he talks about having an accountability partner, right? So that way somebody who you sort of make the social contract with to engage in the healthful lifestyle activity. The literature is pretty strong that if you have a buddy, you're more likely to show up because you don't want to let the person down. So from that perspective, I think it's really important. And then what we really try to do with some of the health fairs that we engage with is we go and we have people fill out a series of surveys. And the surveys are not perfect. They're not idealistic. But the point is we can estimate somebody's VO2 max on the basis of a couple of questions, right? And then, what does the VO2 max mean, right? Okay, the maximum amount of oxygen your body can consume per milliliters of oxygen per kilogram of body weight per minute, okay? Well, that means nothing to the average person. So then you got to take it a step further, and then we realize, okay, we got to translate it to, well, what's your body weight? What is your VO2 max? How much oxygen does your body produce? And then once we know the oxygen consumption, how do we translate that into calories expended? Okay, so now it becomes a number. Oh, so if I go to the gym and the treadmill tells me I'm at this number of calories, I just got to hit that number, right? And so it just like eliminates all the friction to try and get down to like the simple act of just showing up and hitting that number. Yeah. And there are some exercise programs that have these type of metrics, like Orange Theory is one that is like it's very metric driven. They have big screens and it kind of tells you your heart rate and how you're comparing to other people. And so it's sort of gamifying into a certain degree the exercise experience, so that way it's more engaging, I guess is the thing, instead of sort of assuming that we ourselves have all the ability to get up, go to the gym or go for a walk. And we've talked about that too. A gym doesn't have to be a physical location where there's weights and treadmills. It could be walking out on a beautiful day like it is here in Philadelphia.
You're a runner, right?
Yeah. So and I completely understand and agree with what you're saying to a point that it is all these metrics, they really, in one sense, they do help people stay focused and have accountability. So there have been studies, and we're developing stuff. We just, with one of my colleagues at Penn, we just recently submitted a grant for a pilot study where instead of just telling someone, counseling a group of people to eat healthier, if we can have some metric where we can measure things in their skin that are related to their vegetable intake and then show them as they increase their vegetable intake, there's a biomarker that we can measure that you're having an improvement. Things like that to test scientifically if that will help motivate someone to stay on it. There's been lots of studies, things even not related to exercise. Let's just say checking your skin, moles and stuff like that. They've done studies. I was actually involved in one where they took pictures of your body and then there was a reminder. It was sent to you. It said, this month, check all your moles and all this stuff. And so it was an app. It was a reminder. You could look at the picture. You could compare it. You could do all this stuff. And they did that for a year. And then as soon as it fell off, they looked at, without that, how long did people continue to do that and continue to do these checks? So I do hear what you're saying. And I think with technology, it's great. The flip side is, I think that all these people, though, think oh my God, okay, so I want to start running. I want to run a marathon. So I have to know this and this, and I have to have the perfect shoes, and what's the diet plan, and what's this, and what's my training plan. Yeah. And then they sit on the couch for 6 months and really just listening to the body and just get out there and start moving. So they're paralyzed. It's like paralysis by analysis.
I think
right?
That's the victimization of just capitalism, kind of. It's I remember when I first started working out, I needed the Nike dry fit shirts because how could I work out in cotton?
Right, exactly. That's what it is. And what's my Garmin watch telling me? What was this run? And this and that, So it is a double-edged sword.
Yeah,
I think.
For sure.
Yeah. Dr. B, you've done a lot of research on wearables, actually. You want to talk about that?
Yeah, so around the start of the COVID pandemic, a lot of people were sort of taking advantage of the low-hanging fruit about, let's do a survey, right? Because all in-person research, unless you're trying to find a vaccine for this virus, pretty much a lot of research was sort of modified at best, completely stopped at worst, and projects had to just not happen. So as we were going through the pandemic, I kind of thought, well, with some of this wearable stuff, a lot of it's self-report. Mm-hmm. And I can't think, it's not, it's not perfect, but it's better than self-report, is people have, about 100 million people right now have Apple Watches or Fitbits, and, over 1 billion people have smartphones. Yeah. And a lot of the newer smartphones, depending on if you're an Android or you're using Apple, or if you're using Garmin watches, whatever it may be, a lot of these tools are collecting the biometric data that you've mentioned. And so I said, well, maybe, there's been classic papers that have said, well, if you look at self-reported physical activity, the average person, about half of the people will tell you that they are meeting the ACSM physical activity guidelines, 150 minutes per week. And about 30% of people say that they're doing the resistance training recommendations, 2 days a week, whole body, or maybe 4 days per week of split routines. And but when they put an accelerometer on somebody and they actually see how active people are, 92%, I believe the statistic is, are sedentary. And so it's not 50%, it's actually 10% of people are actually doing enough activity to improve their health, or at least to maintain and hopefully keep risk factors at bay, because that's what the 150 minute per week recommendation is designed to do, to keep away cardiovascular diseases and diabetes and maintain long-term health and well-being.
Which is the bare minimum.
The minimum. That's the floor. That's the floor.
And I thought it was from the federal government guidelines, it's 150 to 300 minutes of moderate intensity exercise per week. So there's MET minutes per week, so moderate to vigorous intensity. So 150 minutes per week can be broken up into either 30 minutes a day times 5 days, 3 days per week of 20 minutes of vigorous. You can mix and match it as much as you want. But the 300 minute, that recommendation actually comes for people who struggle with overweight and obesity. And the reason for that is that
oftentimes the 150 minutes per week is not enough to either get somebody into a caloric deficit where they're going to be able to continue to make substantial or meaningful gains on their body weight status. And also because there is such about 50 to 60% of people, you see a lot of people who lose weight regain it. They sort of yo-yo diet up and down. That 300, if you do 300 minutes per week, people who generally engage in that number, that specific target, do better at not regaining the weight. So the 300 is sort of this broad thing. The 150 is sort of, like you said, it's the floor. And so I really got interested in saying, okay, like we have all this survey data, and it's not really surprising that people are either more sedentary because they can't go to the gym and they're stuck inside their house. But I knew a lot of people also who became more active, right? And so like they actually had time, they were working from home, they didn't have to commute 30 and 40 minutes to work anymore. And so now they had time to go do that run first thing in the morning. And so I really was interested in saying, well, let me look at the health app on all these devices and let's standardize it and let's try and come up with some Z-scores to figure out what's going on. And no surprise, across all devices, we surveyed, it was an international physical activity survey, we call it the PAC-19 survey. We found that, of course, in the first two or 3 months of the pandemic, you start seeing like activity levels for the majority of people on these accelerometers just going down and down and down. But then once things started opening up sometime in like the end of June, early July, you start seeing them ticking back up again, right? And so they sort of did cyclically change. What would be ultimately interesting in the long run, and you can look at some of this now with some of the NHANES data, is what's that data going to look like into the future, right? So like if people are sedentary who were once active, are they now stuck being sedentary? How many people, once they were able to engage and find resolutions to become more active? That's sort of what we're into now. But yeah, so that was like the big one, that everything sort of, at first we came up with the survey. How do we do this in a way where it's not going to be really a burden, and asking all the questions about VO2 max and heart rate variability? But we looked at a lot of those types of values. Heart rate variability went down, and so that's not good because sympathetically speaking, you're not as able to reflex as fast when you have changes in oxygen consumption. But so we did some wearables with that. And then, now really thinking towards the future is we're starting to think about, a lot of people prefer being home and exercising. Peloton fitness is really a big thing. And so really we're starting to think about doing some work with virtual reality. So creating some activity and collecting some biometric data in VR and trying to simulate as best we can to a real world experience.
Yeah, Chris talked about that. Was that last podcast?
It was. He was the last person we spoke with, I think.
Yeah, Chris is he got his PhD here at Drexel in exercise science, and now he works in Alabama, I believe. And what's that called? Exergaming. Right?
Exergaming.
Yeah.
And we have somebody at Drexel, Dr. Steven Samandinger, who does a lot of work with exergaming as well. And he focuses on the motivational aspect of using the game to help entice people to maybe persist longer. Maybe we can have him as a guest in the future. That'd be great.
Oh, yeah, that'd be really cool.
Yeah, I mean, we are social creatures, right?
Yeah.
And and I think your point is very well taken about, if you have a goal or something, so let's say like a run, it's much easier to make sure you're getting in your runs if you're signed up for a race. Right? More importantly, if you're signed up for a race and you tell your friends and family that you're signed up for the race. Because if you're just signed up by yourself, then, race could come, whatever. But then if you've told someone else, now there's a commitment, right? So, I think very few people have the true, not motivation. I think motivation is really crap, but the internal grit, desire to pound it out day after day and do the exercise and do all this stuff. Because, our brains, we're wired for comfort, right? We want to minimize stress. We want to maximize our comfort. So there's a lot of evolutionary reasons why it's better for us to eat these high calorie foods, protect ourselves, not do all this stressful environment. But I don't know, it's gone way too far. I mean, clearly our society is going off the rails. I mean, it's crazy the amounts of obesity and physical inactivity and all the chronic diseases we're facing. And even in the military, I read that it wasn't that long ago, they had a report on NPR, but it came out of this big report to Congress. They're saying how many people now are the young people that could be recruited into the military. And it's hard for them to even get the numbers of people that can pass the bare minimum physical requirements because, there was a big study about kids not playing. They're in, gaming, doing all this stuff during childhood. So their lungs are literally not developing the same way because they're not outside running all around during critical times of development. Yeah. There's so many things that I think are changing where, again, going back to the osteopathic thing, life is motion, right?
Yeah.
And really, everything is designed to be moving. We were not evolved over millions of years of evolution to sit behind a cubicle, not be physically active, and eat super calorie dense food.
Yeah, I mean, if you think about it, our current society is only a fraction of what we have been evolving into, and we just don't have time to adapt yet to this lifestyle.
Yeah, if you look at large epidemiological studies from around the world for people that were I don't want to misquote some of the studies, so I'll just say in generalities, they've looked at these groups of people that eat, that are very physically active, not that they work out per se, but they do physically active things all day, every day in these parts of the world, and then they eat primarily unprocessed, plant-centric type of diet without all this processed food that are very, very healthy. And then as they become westernized and stuff, their health actually just completely plummets. And initially it's worse risk than Americans and Europeans and people in the Western world. And they think it's almost like a shock because they're going so far to all this processed food and they're not used to it. And their rates of, colorectal cancer and all these other different problems are just skyrocketing. So, I don't know. I think that it's a big problem and people don't realize. I think that exercise is critical. And I really think that exercise can be a cornerstone habit to really allow people to use their exercise activity to have knowledge about eating a healthy diet. Because I do think, though, that there's a ton of people that exercise and think that they're okay and then eat a completely crappy diet, and they're not really decreasing their risk that much.
Right.
I feel like it's a young guy thing, too, specifically, right? I remember specifically my stepbrother at the time, he was getting into weightlifting and he was eating French fries. I go, isn't that a little counterintuitive? He goes, I'm carb loading.
Yeah, right.
Yeah, he's like, it tastes good, right? So yeah, I also feel like one thing eventually comes first before the other. Yeah. Hopefully, if you sustain, because I feel like if you are exercising without the intent of being healthy, then it would probably fade eventually away, right? Because we talked about there's a several motivations for why someone exercises. Right?
Yeah, well, those ones aren't necessarily scientifically based. The examples that I gave were oftentimes when I was in the business world, in terms of how you would convince somebody to take the next step, right? Because I was running at the time, it was Bally Total Fitness Health Club, big, large chain you might have heard of. Yeah. And how do you get someone who's sort of on the fence and you're like, how do you get them to convince them today to sign up? Because of course, selfishly at the time, I wanted the commission, right? But at the same time, I never felt bad when I would convince somebody to do something that's good for their health. And so what we would ultimately do is we were trained that there's four, there's really multiple, but really a lot of the 4 buckets that we were trained on how to really get someone to come over and begin enrolling in the gym and start becoming more physically active and do exercise. Was a lot of times it would come down to money. I think there's unnecessary costs that the person, or it's too expensive and we would have to overcome. It's really not that expensive when you think about not doing it and the costs to your health and what those medical bills will be down the line, if you put it in real numbers. And so that's one way. And then also costs that people would spend on coffee and daily frivolous spending. It adds up and it would be 3 or 4 times the amount of money that someone is spending on a gym membership. Yeah. The second thing was commitment. So they have issues with commitment where they don't want to commit because they have some level of self-doubt that they're really going to be able to accomplish the goal. The third thing is support. They feel that they're doing this alone. And so they don't have the confidence that they're going to
What was that? Oh.
be able to continue to sustain. Like they might start and then as soon as it gets tough, they think they'll quit. So they're not totally sold. And then what did I say? Financial, so money, commitment, support, and there's one more that we were trained on in terms of how to overcome it. Time. Everybody says they don't have enough time, and that's a bunch of BS as far as I'm concerned.
You make time for anything you really want. You know,
people, the busiest people in the world. If you look at the busiest people in the world, I mean, doctors, PhDs, college students that are preparing for medical school, people in the military, everybody. Pretty much everybody is busy, right? So that's what we've actually replaced. How's our things going? I'm busy. Okay, like how are you doing?
Right.
And so we're all busy. It really just comes down to you're not prioritizing it, and people don't want to face the fact that they won't take accountability for their inaction, and they're just probably being lazy. And I don't want to say lazy because like in terms of a person's body weight status, that's not what I'm saying. I'm saying like they won't take accountability for the action, that they won't make the time or prioritize it over other things. They have plenty of time to do things like binge the newest season of Ozarks on Netflix. It's nice weather. Let's go for a walk in the park. That's good. A walk in the park is good. But we definitely don't need the ice cream cone. So like little things. And I think like prioritizing your health is something that it's going to sound cliche, but if people don't prioritize their health, then the health is going to prioritize them and tell them it's going to make the decision for you if they keep putting it off.
So Randel, you do a bunch of stuff, right? So how do you make time?
Yeah, I mean, I make it that it's a priority that I have to do it. I mean, I literally schedule it in, right? So so again, going back to like the whole brain thing. So, it's a myth that we can multitask in all this and have this divided attention, right? So I just try to really focus, and I tell the patients this too. Like even as a doctor, unless I'm on call, my phone is set to like do not disturb during certain hours. I choose when I check my email. Right? I prioritize these different things to do when I have high energy. Then things that are lower priority, I do when I'm, at the end of the day when I don't need as much brain power because it's not as important to me, all these different things. So plus I think it's the realization that as a physician, just like an airplane, you have to put your mask on first before you can help anybody else, right? If you don't take care of yourself, you can't really take care of anybody else. And your point was well taken too, that a lot of people, they just, I was talking to some family members and stuff when the pandemic happened, or about, different diseases that are like, infections. People were so worried about it. But then I was showing them the numbers from the CDC of how many people die of cardiovascular disease and all of this stuff, right? And they're like, yeah, and I know that, but we're going to die from something. And that's so far down the road that we can't really see it, right? And the other thing is this, with modern medicine, you're probably going to live, much older, but do you want your last 25 years of your life to be taking 15 different medications and not being able to care for?
Is it a quality life?
Right.
Quality 25 years,
Yeah, so people they don't have the insight to look at that, right? And still, I think too, it's like, so visualization. I was big about visualization. I can't remember if it's in the Atomic Habits book that you were talking about or another one I read, but they're talking about, first you're the person that goes to the gym or you're the person that runs or whatever. The first thing you have to do is just every morning, you have your clothes laid out, you get up, you put your shoes on. And you just go to the gym. You don't have to work out. Just for 5 or 10 days, just go to the gym. Now you're a person that goes to the gym, right? Sure. And then you start these habits. And it's the same thing like, becoming a doctor or something. Before, you're wearing your stethoscope. You're in there. You're already visualizing the fact of what it's going to be when you are that person. And then you're internalizing the information that you're learning and what you're doing because you're viewing it through the lens of what the outcome's going to be.
Fake it till you make it.
Exactly. And so I think that is very, very powerful. And it's those habits of how we can prioritize exercise. So I want to say one other thing about exercise and stuff. So one of the things as a physician that we tell our patients, you were talking about gym memberships and stuff. So I personally tell my patients, I don't go to the gym. from a health standpoint, everything, all I want you to do is start walking, then eventually you can start jogging, all that stuff. Do body weight exercises. It costs zero money. It's free. We can give you a whole program. You can get jacked or whatever you want, right? You can get a pull-up bar or a TRX strap or something like this and pay a fraction of the cost. So all this stuff, if I don't have enough money to do this, I don't have, it's all
push-ups are free.
Push-ups, sit-ups, planks, all
Burpees,
these things. There's so many things that when you're just getting started, it's just a matter of just, you have to start the habit.
Couple things. So one is your last point really reminds me, and I think what a lot of that, what's going into that thinking about I have to have is when someone says, all right, well, if someone who is caring for me tells me that I should do so, I guess I have to do it. But if I'm going to do that behavior, I have to optimize it versus optimization versus being sufficient, right? And so okay, so I guess, I went to the doc, my blood pressure is high. I have to do something about it. So, I guess I'm going to go to the gym. I'm going to buy the newest shoes. Cause if I'm going to be an exerciser, I'm going to optimize it and do what the best people in the world who exercise do. Right. I want to align myself with exactly what they're doing versus really what all we need to be doing is what's the target, right?
Right.
What is sufficient to hit the target? Is the target to be the world's strongest person? That's a certain target, and that requires a certain kind of training. If the goal is to minimize your risk for cardiovascular diseases so that way you can live a life with quality and with high wellness, that's a different threshold. And so the importance of just really just getting started, I think, is important. The other point that I think that is important that you brought up is how patients will often look at your recommendations, or in the particular case of cardiovascular disease, oh, that's so far away, is really, I think it's helpful that when people are considering and thinking like that, to put it in real terms and look backwards. So when we've done studies for chronic kidney disease patients, we show once you're on dialysis, a lot of people don't make it to stage 5 because oftentimes they'll die of a cardiac issue by phase 3 of chronic kidney disease. A lot of times there's a big 3 versus 5. There's something's going on. And so really what we try to do is show the person is okay, these are what the data says. And so you're getting treatment today and you're looking forward to the future. But if you start at the average life expectancy for how long someone's expected to live with this, and you look backwards, and that's X number of years, Y number of days, Z number of hours. Now it's well, I want more than that. And the way we're I heard it, but I never believed it, was when on the Tim Ferriss podcast, he had brought this idea up that the average person, by the time they are 18 years old, by the time they graduate high school, the average person has already spent 80% of the total time that you're going to spend with your parents before they die. And that's a real number, right? And so a lot of times I tell this to my students all the time, is when you graduate, it's very easy to move on with your life, get the apartment, move out of the house. But as much as you've been living with your parents, you might look at them as sometimes very annoying or sometimes, causing a lot of stress in your life. It's important not to forget about them if you have a good relationship with them, of course. Yeah. Because I have quantified it as, both of my parents now are just about 60. So if they live to life expectancy 74, on average, 74-ish, 75-ish, that's 15 years. But if I only go home twice a year, the reality is I might only see my parents 30 more times in their lifetime. And that's kind of scary to think about. So I'm buying those damn train tickets. I'm going on that flight. I'm going on that vacation with them because I'm not going to live a life of regret. And so I think those same principles they look forward as it's this endless date versus starting at the end and saying, well, the data says this is going to probably somewhere around here is going to be this is the deadline. Yep. So if we turn and look back, this is all the time you got left, and it might be closer than you think. And so that it puts in real terms, and I think that's very powerful for people when they're faced with that.
Have you ever listened to Cats in the Cradle?
I have not. I have not.
Yeah. Well, I mean, you bring up a very good point. And as you get older, so I'm about to be 44, and it is, you don't realize when you're 20, and then when you're 30, and then you're 35, and then it's just every year you're like, holy cow, life is going faster and faster. And statistically, maybe more than half my life is over, right? And so you're thinking about the quality of life. What do I want out of this, right? We put all this money. There's countless, examples of people that I know. Let's say is physicians, lawyers, PhDs. Also, if you work your life away, you do all this stuff, and you think I'm going to have my health later. When I retire, I'll have time to exercise. I'll have time to eat healthy. I'll do everything. Well, this golden age of retirement may never come, or it might come, and then you're like in a wheelchair, you have a heart attack, you have a stroke, or then what,
Sure.
So people just, you really don't realize this. And you could still be hit by a bus tomorrow. None of us know this. We don't have it. But if you eat healthy, if you exercise, if you have social engagement, if you get good quality sleep, you do all these things, you're giving yourself the best opportunity to have healthy aging. There's this difference between there's this concept of lifespan versus health span. I don't know if you've heard about these things, right? So,
no,
so
actually.
it's like everybody wants the death where like you're super healthy, and then all of a sudden it's like you become unhealthy and you rapidly die, right? But what we have is, you're chugging along, and then you're just having this slow decay for 20, 30 years where you have all these chronic problems, and you're going to the doctors all the time, and you're taking 15 medications, and you can't play with your grandchildren, you can't do all of this stuff.
Sure.
And it's that slow decay. So they have a low lifespan, right? So we can, in medicine, we can prolong your life, but not necessarily your health. And people don't realize how much they are in control of their health span. Right? It's all these choices that you're making on a daily basis. Smoking, drinking, eating processed food, not exercising, not sleeping well. It's adding up day after day, year after year, and it's having a toll on your internal body. I wanted to bring up one subject or one study. Just reminded me, I thought about this in the beginning and then I didn't mention. So for a grant that I just got, one of the things I use is pilot data. There was a great pilot study published in JAMA, the Journal of the American Medical Association. I don't want to exactly quote. It was somewhere around maybe 4 or 5 years ago. But what these people did is they took young, healthy, quote-unquote healthy individuals in their 20s and 30s with no known cardiovascular disease or whatever, okay? And they looked at the American Heart Association has the, what is the American Heart Association? I think Simple 7 and stuff. So it looks at diet and exercise and alcohol and smoking and blood pressure and BMI and things like this. It has a score. And they did advanced neuroimaging to look at microvascular pathologies in the brain, okay? And they looked at that in association with the person's modifiable risk factor score, okay? And there was a direct association. So they have, and I showed the pictures, and they're like, okay, here's a 21-year-old male, a little bit of high blood pressure, a little bit of high cholesterol, doesn't exercise that much, drinks 8 alcohol drinks per week, has a little bit is overweight, a BMI of like 28, 38 or so. And look, this is their brain versus look, here's a 30 or 28-year-old female that is exercises, doesn't drink, better, everything, and look at the vasculature in this person's brain. And it's decades before they have a stroke or anything. Yeah. Right. So these things are happening. And in the military, if you go back to the Korean War, right, some of the big landmark studies was they were doing autopsies on all these young kids, 18 to early 20s, that were dying. And they were like, holy crap, these people have all this cardiovascular disease. These are elite soldiers over fighting the Korean War. Wow. This stuff is happening. It's a slow process. And so my research, what I'm trying to do, the big grant that I just got that we're working on over the next 3 years is we're doing secondary data analysis of this thing called LIMBIC, which is the Long-Term Impact of Military Relevant Brain Injury Consortium. So they are enrolling veterans from across the United States. They're doing a whole battery of clinical tests. They're doing advanced neuroimaging and blood work. And then they're following them longitudinally with repeat neuroimaging and stuff. Mm-hmm. And so we're looking at the analysis of their traumatic brain injury exposure history, like how many they had and the severity and stuff, versus this advanced microvascular imaging we're doing in the brain. And then we're looking at a whole panel of modifiable cardiovascular risk factor scores in association with that vascular imaging. And then as we look over time, our hypothesis is it's that modifiable cardiovascular risk factor profile that's going to be driving the long-term pathology, not the remote history of head injury, which is that static event. All of our preclinical studies show, again, you have trauma, no different than you cut your skin. You cut your skin, instantaneously the body starts to heal. But if you keep cutting your skin every single day,
that's right.
It's just like you're smoking cigarettes every day. When you're sleeping at night, your lungs are trying to heal. And then you wake up in the morning, you take that next puff of the cigarette, or you eat your next donut. It's the same process. It's a chronic inflammatory state.
And how many of those modifiable risk factors is something the physician actually can modify? Like 0, right?
Yeah, it's the patient's control.
Yeah,
right?
yeah.
Yeah, that's all we can do is empower the person. Right? No, we can modify in the sense that I can write a prescription for a cholesterol medication. I can write a prescription for a blood pressure medication. And yes, if your blood pressure is lower, if your cholesterol is lower, regardless of if it's from a medicine or a diet, you are going to decrease your risk for cardiovascular disease and stroke and heart attack. But over the long haul, it's not the same thing as doing that holistic diet, exercise intervention. And all those drugs have side effects.
Yeah.
So you might be on a cholesterol medication for 20, 30 years, but then you're having muscle problems, you're having all these issues.
People forget that, the thinking is as well, if you prescribe me a statin, my cholesterol gets better. I'm saved, right? And Paul Thompson, who's one of my mentors, he's chief of cardiology at Harvard Hospital. He's presented data. Yeah, I mean, if you're going to take one medication to live for the next 5 years, that's probably a good one. If you have if I have to prescribe somebody a medication, that's a good one. But people forget that particular medication does not just follow the pathway of the mechanism. It affects a whole cascade of enzymes, and a really good way of explaining it would be when I was working in cardiac rehab, we would work with folks about people who have congestive heart failure, and you're like, all right, well, what's going on with valves? And all right, well, if this valve is having issue and the heart's not strong enough, it might pump it back. And it becomes bidirectional flow. And then now I have bidirectional flow. Now I'm filling here, but I'm also adding to the fill because I'm pumping through the squeeze some of it back in. And now this becomes enlarged. And so that feeds forward. Now I get buildup in the lungs. And so people forget that, yes, medication could fix me, and then I can eat all the hamburgers and hot dogs and French fries that I want because now my cholesterol is fixed. I'm on a medication, but that's all right because everything else is good. The problem is they forget that biological mechanism that medication is designed to impact is also impacting the holistic system and all of the other systems that mechanism may serve. And so then you need blood pressure. You often need 2 medications in order to control it. Depending on your race and your age and your sex, there's different medications that you're going to prescribe to treat it, right? Yeah. And so again, it shocks me as an exercise physiologist the lack of urgency when someone has to be put on medication to control their pressure. And I don't want this to be heard the wrong way, that because there are genetic reasons why some people, right, understood, but the lack of concern when maybe you have genetics, but also deep down that your dietary habits, you're not being physically active. You're not taking care of what you can control to affect the problem. Yep. And just that is concerning because this is a very real problem. This is the reason why when we prescribe exercise, we treat people. Yeah, your cholesterol might be controlled, but you still have that risk factor.
Well,
and so I like to see it as with a lot of medication, you're kind of just cutting the tip of the iceberg, but the rest of it's still under there, the overwhelming problem.
And there's genetics, and now there's this whole new emerging field of epigenetics and stuff. So you might inherit a risk for something, but that doesn't mean that it's going to manifest. So, you might have, let's take something extreme. Again, I don't want to misquote science and stuff here, but let's say, you have some risk factor for a major cancer and, your mom got it and your grandmother got it and this and that. But, there might be a lot of lifestyle factors that could help from an epigenetic standpoint and sort of turn on or turn off whether or not you're going to get that. And again, it's a holistic thing. So if you go back I keep going back to diet and exercise because it's not like there's a separate exercise program that's going to be good for the heart or the kidneys or the brain. It's not like there's a separate diet that's going to be good for the heart or the kidneys or the brain, unless you've got some chronic disease and it's a really specific, electrolyte or something you need to take care of, because you're in renal failure or something.
Right.
But by that, a heart healthy diet is a brain healthy diet, is a kidney healthy diet, is a body healthy diet, right? Mm-hmm. Cardiovascular exercise and resistance training is good for the brain and the heart and everything. It's a holistic approach. I think that it's a real big problem, and our whole medical system is not even designed to treat this. We're not designed to really promote health. We're designed to treat problems, right? Yeah. And we want a problem that we can give a pill for, right? It's very, it's a cyclical problem. Doctors really, the majority of doctors don't take the time to counsel patients on lifestyle factors because it takes time. The majority of patients aren't going to listen. They're going to say, oh, the doctor just thinks I'm overweight or I need to exercise more or whatever. Mm-hmm. And they're not getting reimbursed for that the same way. There's a whole system around this.
Well, I remember you spoke about this to me almost a year ago, right? And you're like, well, it's really it's also the incentive of the doctors too. It's like the system, it's not like some physicians, but I feel like it's also the system, right? You were saying where promoting that education is going to take, 30 minutes? And if you're getting paid hourly or per patient, prescribing a medication is going to take a lot less. You know what I mean? So it's like the system is set up to... Right?
Yeah, there's different there's different levels of billing. And so if you're just doing some counseling, you can't bill the same level unless you spend, a whole bunch more time. But if I'm prescribing a medication, I can spend 3 to 5 minutes and bill at a higher level and get paid more money to prescribe a medication than to counsel someone for 30 minutes.
And I think conservative thinking too is a lot of people walk into a doctor's office, they're like, oh, I want my doggy bag of medications. They want their prize or their whatever. They can't tangibly see the effectiveness of education where they could just, you know what I mean?
Yep.
So they probably wouldn't come back either.
Right.
Yeah.
You know what they do in Massachusetts? When I did my PhD, it was in Massachusetts. If you, so I worked at a hospital just to help offset some expenses, and I got to know a lot of the doctors. I'm still friends with a lot of them. In that state, if the incentives for finances, right? So coding at a certain level, right. If someone came in for chest pain into the emergency room, and then they had to be admitted to, let's say, I ran a cardiac day stay floor. If that patient was discharged and they came back within 30 days, you don't get paid for that.
That's national as well,
right?
Yeah, let's just say hypothetically, when I was a medical student, there was a Mr. Jones that had congestive heart failure. It was on the cardiac unit that we were on, and person was in the unit and for several days, and then we got him all squared away and had education and Mr. Jones, this is the diet. You have to be very, very careful, and you have to do all X, Y, and Z and all this stuff. And talk to the family. Well, the next morning, Mr. Jones's name is still on the. Mr. Jones is not a real person. I'm just using Mr. Jones. Yeah. Mr. Jones's name is on the roster. And I'm like, this must be a mistake. Well, no. Mr. Jones on the way home stopped and ate a foot-long Wawa sub, and with all that sodium and stuff, and was back in congestive heart failure. Yeah. Your point is exactly correct. It's a revolving door. That it's viewed that if the doctors made the error, if the person returns to the hospital within 30 days.
Yeah.
Right?
Yeah. Well, I like to think planned obsolescence is invading medical care.
Yeah.
Yeah.
So the only way around it then would be we have to try and incentivize to put the time in, right? And de-incentivize the medication, I guess.
Well, think about this. I'm a researcher and I have grants and everything, and I like applying to the government and getting these grants. Yeah. But aside from that, I think that if we took all of the budget that we put into finding the next cure and doing all these things, and we took and cut 50% of that, and took even 10% of it and put it into initiatives for primary prevention, we would be so much further ahead in the long-term health of our country, right? Yeah. We, instead of trying to treat a problem and prevent it from happening, we wait till it's catastrophic. It's like this. This is another analogy I tell my patients. Let's say you buy a brand new car. I ask them, again, Mr. Jones, if I could give you a car today, what kind of car would you like? And let's just say they say a Lamborghini or a Porsche or whatever. I'm like, okay, so let's say you get this brand new car and you got the owner's manual that says, you have to rotate the tires and put this type of oil in there and only use premium unleaded gasoline and everything. And instead, you don't rotate the tires, you don't change the oil, you put diesel fuel in there and you run it till it's about dead, and then you take it to the mechanic and you say, fix me. And still, the mechanic can say, you can still turn this around if you start putting unleaded gasoline in there and you start doing this. And the person says, no, I still want to put diesel fuel in there. Just give me some additive that I can put in there so I can still do what I'm doing. That's the medication, right? So that's like the mindset of what we're doing here, right? We're not treating...
It's not built that way, yeah.
Right, and we're not treating the underlying cause. We're just putting the additive into the gas can to let it keep running.
Mm-hmm.
So as we start to wrap things up, I do want to make sure that we give you opportunity to talk a little bit about some of your studies. You've talked about some of them, and congratulations on the grant that you were just awarded. That's very sometimes it's pretty hard to get grants. I know from applying for several myself, and we put in an R01 recently, so hopefully we'll get some good feedback on that.
That's awesome.
So is there anything in particular? So what would you say is your primary research area? So if you were talking to the average person, or maybe some of our listeners here, and someone said, what's your research all about? And what kind of studies are the thing that really drives you to do it?
So what really drives me now is looking at the actual mechanisms. If we can show objectively that, yes, when you have brain injury, there is a problem in the brain, and we can show that objectively, but that we can show that there is healing, just like any other part of the body. And then it's that collective looking at how these host of modifiable factors are driving long-term problems. So, there's a lot of studies showing after you've had a neurological injury, you sort of accelerate this normal age-related cognitive decline. Mm-hmm. And we're looking at all of those factors. So I'm not doing it right now, but we were looking at some preclinical models where, again, we had at Penn, there's a swine model of brain injury, and we were looking at microvascular pathology acutely versus in the subacute to chronic phase after injury. We worked with some collaborators who have this, again, preclinical animal model where the animal has diabetes, hypercholesterolemia, and we're looking at the slow progressive increase. So all my research right now is going to focus on these advanced neuroimaging metrics so we can hopefully add to the scientific literature showing that, yes, you had this injury, you can't take that away, but there's all these other factors that are really way more important. Mm-hmm. And how do we switch that narrative to inform the patient that, look, don't dwell on this, the fact that you had this injury you can't change. Focus on all these things you can change. I also, as a brain injury doc, I do collaborative research with other investigators that are looking at different diagnoses for traumatic brain injuries. So we have a grant with a collaborator at Temple that's looking at eye motion problems with a virtual reality headset after brain injury. And we have some other stuff that we're doing on blood-based biomarkers, trying to figure out, when someone has a concussion, let's say a sports-related concussion, they don't usually go to a brain injury doc until 2 to 3 months later when they're not getting better. And by that time, it's really hard for us to tease out, did you really have a concussion, or is there other psychological comorbidities here and other things? Exactly. So how do we develop a blood test that will still be around that we can measure those 2 to 3 months later, right? Because all the stuff that is being done so far to date is sort of in the super acute phase. Just like if you're having a heart attack, you go to the hospital, we can draw some blood, and there's this things called troponins, which is a protein that gets spilled into the blood. But by a couple weeks later, it's gone. So same thing with the brain. When you have an acute injury, we can see these things spilled into the blood. The body has a way of getting rid of those proteins in the blood. So how can we develop biomarkers to
correlate with it and
2 to 3 months later
indirectly give you those markers? That's interesting.
Because in brain injury, it really is, we don't have a good diagnosis right now. So it's non-specific diagnosis, which leads to non-specific treatment, which leads to non-specific outcome. It's the way it is in the brain. Let's say sports concussions. So you guys about exercise and sports concussions. Yeah. So think about this. If a woman finds a lump in her breast and she goes in, we do a fine needle aspiration. We then come back and we have to tell her, Mrs. Jones, I'm sorry, you have breast cancer. And after the shock, she'll say, like, what kind? And if I said moderate, that's what we do in brain injury. We have mild, moderate, and severe. Mild is like concussion, moderate is in the middle, and then we have severe, right? And then, based on this moderate breast cancer, we're going to give you treatment X, and then we're going to look at your outcomes. That's what we do in brain injury. But really, in cancer, we don't do that. We say, like, okay, you have a breast cancer, your cells express this receptor, therefore we're going to give you this targeted treatment, and blah, blah, blah. So we don't look at the underlying pathology in the brain. Meaning, is it an electrical problem from like the axons, the actual nerves? Is it a microvascular problem? Whatever. And then what specific region of the brain? We just, in general, people get these sort of individualized therapies. It's very, very hard to do a research study to show, what is having an effect. So we're looking a lot at that. Well, like, how can we use objective markers to better screen people to say that you have a better heterogeneous population to go into this clinical study to look at a specific outcome, right? Because I'll say one more thing. Like, so, you could have, from a sports concussion standpoint, let's say you're playing football, soccer, or whatever, depending on your age, your sex, where you got the force on the body, which way your head was turned, all, your neck strength, all these different things, you're going to have different forces going through the brain, which, let's say, to make this simple, if you go to the preclinical models, like they have my colleagues up at Penn, they can do an injury where it's rapid rotational acceleration, deceleration, like you're punched in the head, kicked in the head, during MMA or something, or a car accident, you go forward and backwards. Now, again, they can do it in sort of a right to left direction, a front to back direction, or side to side like this. If you look under the microscope, you're going to get the same pathology, but it's in different regions of the brain that are affecting different pathways, so you're going to have a different clinical outcome. Right. You understand what I'm saying? Mm-hmm. So, anyways, I know I talk a lot. I went off on a tangent, but that's a big issue from a sports-related concussion standpoint, I think. Going back to exercise and nutrition, prehabilitation, this idea of being in the best shape as you can possibly going into an injury. If anything that the COVID pandemic taught us, it's a real wake-up call, right? Yeah. And how more Americans aren't like, well, holy crap, let me get in the best shape possible so when the next pandemic happens, I'm less likely to have a severe outcome, right? Like, I think that was a real... As physicians and public health officials, that was a real lost opportunity to impart that on the American people. Impart that wisdom.
I agree. Well, this has been terrific, Dr. Swanson. I appreciate the time. And where can people follow you? You're on the social handles?
No, I don't have anything.
No social?
They sort of discourage that as a physician. I don't have anything.
Enroll at UPenn, I guess, right?
Yeah. So there's a bio up there.
On your website. Gotcha. Well, thank you so much once again. This has been terrific, and we'll get off the podcast and we'll talk so I guess we'll collaborate.
That sounds great.
Thank you so much. I appreciate it.
Thank you.
Thank you very much, everybody. Talk to you soon.
See ya.
Bye.
Bye.